Welcome to today's lecture on Chapter 8, which is entitled Circulation, and Chapter 14, which is entitled Cardiac Emergencies. I've kind of grouped these two chapters together because I believe that cardiac emergencies and the circulatory system go hand in hand. Before we actually get into the lecture, I'd like to give you guys a few statistics. The first one really is that heart disease in particular takes the lives of about 350,000 people each year. I think what's more alarming is that many of these individuals typically die before they ever reach the hospital. And I think that this provides evidence for the fact that first responders, first of all, are very important, and more importantly, that we as first responders really need to provide care for our patients within that first 4 minutes. Remember the clock, and remember that anything out of 4 minutes could cause irreversible damage to both the heart and your patient's brain, right? And so I think that as we think about these statistics and we realize that there are going to be a lot of people who are dying in the emergency field, I think that this could be discouraging, but I'm here to say don't let that discourage you as a first responder. I think you as a first responder are important in an emergency situation, and more importantly, emergency care in the field is very critical to saving lives, and you are a critical component to the emergency medical team. At the center of the circulatory system is the heart, and so when we think about the heart, we're going to think about it as a hollow muscular organ about the size of your fist. So if you're sitting at your desk, go ahead and make a fist. What they're saying is that your heart is about this size. So it's not as big as we envision it to be. It's definitely not as big as we might see it on television. And so when we think about the heart, we need to think that it's about the size of your fist, which is relatively small in nature. And when we look at the anatomy of the heart and the anatomy that protects our heart, we can see that the heart is positioned in the lower left central region of the chest, and it's positioned in between each of your lungs. And so your lungs are in this particular figure are going to represent these pink large lobes here, and we can see that the heart itself is kind of situated, like it said, in the central 1/3 of the chest. What's nice about the heart is that it's also protected anteriorly by your rib cage, right, and also by your sternum, and then posteriorly it's protected by your spinal column. So there's lots of protective forces in place to protect the heart from being injured, right? And so we've got the sternum and the rib cage anteriorly, and we've got the spinal column posteriorly to protect our heart. Just basic anatomy before we move to the next slide is that the heart contains 4 chambers, 2 upper ones which are called the atria, and then 2 lower ones which are called the ventricle, and we'll kind of talk about each of these structures individually and their role in the circulatory system on the next slide. So going back to the anatomy of the heart, as mentioned on the other slide, we have 2 atria, one which is the right atria, and the other which is on the left-hand side, which is the left atria here. And again, remember these are the upper chambers of the heart. And then on the bottom or lower portion of the heart, we have what we would call the left ventricle, or right ventricle, sorry. And then on the left side, we have the left ventricle here. I think one of the most important things to know is that the right side is going to be carrying deoxygenated blood, and then the left side will be carrying oxygenated blood, which will be distributed to the rest of the body. And so all in all, we have four chambers to our heart. I think when we look at more specific anatomy of the heart also has 2 different valves, one on the right side called the tricuspid valve, which is located right here, and then one on the left hand side called the bicuspid valve. And obviously they kind of get their name based on how many valves they have. So the tricuspid valve would have 3, and the bicuspid valve would have 2. And then the interventricular septum is this little guy right here. So it's this muscular tissue that separates the heart into right and left halves. And so this is the basic anatomy of the heart. On the next slide, we're going to talk about how blood flows through the heart and how it gets distributed to the rest of the body. So now we're going to talk about the circulatory system and how blood flows through the body. And so we would say that all blood enters the right side of the body. So we're talking the right atrium and the right ventricle. And it enters the heart through 2 different veins. The first vein we have is the superior vena cava, which is located here. And then the second vein that we have is the inferior vena cava. And again, these 2 veins are responsible for blood entering through the heart. And so we would say that the superior vena cava is responsible for collecting blood from the upper half of your body, or the upper extremity, so the shoulder, the elbow, your trunk, etc. And the inferior vena cava is responsible for collecting blood from the lower portion of your body, or what we would term as like your legs, right, and your feet. And so once the superior vena cava and the inferior vena cava have collected blood from your body, that blood then enters either through this aspect here or from the inferior vena cava here and goes directly into the right atria, right? And so blood enters through the right atria, right? And remember, this is deoxygenated blood, which is why this half of the heart is blue. And then the right atria will eventually contract. And when the right atria contract, it stimulates the tricuspid valve. The tricuspid valve then opens, and blood is then allowed to flow from the inferior and superior vena cava into the right atria. When the right ventricle contracts, then what we have is blood being pumped through the pulmonary valve, and into the pulmonary artery, which is right here, right? And so once it's pumped through the pulmonary artery, it then gets distributed into the lungs, and we would imagine this white space to be the lungs, where it's going to pick up oxygen, right? And once we've picked up oxygen from the lungs, then what we have is that the blood is then being returned to the heart via the pulmonary vein. So now that the blood is oxygenated, blood now returns to the heart from the lungs by way of the pulmonary vein. And so we have blood basically being recirculated through the pulmonary vein into the right atria. And now it's important to note that this blood now has oxygen, right? And so now that blood has been pumped from the pulmonary vein into the left atrium, when the left atrium contracts, blood travels through the mitral valve into the left ventricle, right? And so when the left ventricle contracts, it is important that this chamber pumps blood through what we would call the aortic valve, right? And so you get blood going through the aortic valve. And why is this step important, you might say? Well, it's important because the aorta is the main artery of the body. It receives all the blood, all the blood that the heart has pumped out, and it distributes blood to the rest of the body. You might notice that the left ventricle, which is located here, really has a thicker muscle when compared to the right ventricle, and that's because it must pump blood to the rest of the body against a much higher pressure in the general circulation, and so it has a thicker muscular wall when it's compared to its right ventricular counterpart. And so again, if we could trace blood flow through the body, we could say that blood is going to enter deoxygenated blood is going to enter through the superior vena cava and or the inferior vena cava. Then it's going to travel down into the right atrium, through the tricuspid valve to the left ventricle, where it is pumped through the pulmonary valve into the pulmonary artery, where it is then pumped into the lungs, where it picks up O2, right? And then after it picks up O2 from the lungs, it's redirected back into the left atrium through the pulmonary vein. When the left atrium contracts, blood then travels through the bicuspid valve into the left ventricle, right? And the left ventricle contracts, it sends blood to the aorta, which is then responsible for delivering oxygenated blood to the rest of the body tissues. So what are the roles and the responsibilities of the circulatory system? I really think it could be summed up in three. It's going to be responsible for delivery of O2 to the tissues. It's also going to be responsible for delivery of nutrients to the tissues, and then most importantly, one of its major roles is to really remove waste from the body's tissues as well. So we can see that the circulatory system has more of a role than just circulating blood throughout the rest of the body. It also has three other major roles. And so we can see that if there's a deficiency in the circulatory system, how this could lead to trouble and or death of our patients in an emergency situation. So it's crucial, it's important that we assess our patients, that we perform our initial assessment, and that we do our vital check as soon as possible, at least within that first 4 minutes. So how does the heart function? I think one of the most interesting things about the heart is that it has its own blood supply, and it has its own artery that supplies that oxygen-rich blood, and that artery is the coronary artery. And the coronary artery's major role and only role is to supply blood to the heart muscles. And so when we think about the coronary artery, we have to think of it from two different aspects. The first part of that is that there's a right coronary artery, and then the second part of that is that there's a left coronary artery, right? And so the right coronary artery, as you suspect, would be responsible for supplying blood, oxygen-rich blood, to the right atrium and to both of the heart's ventricles. And then the left coronary artery, on the opposite end of the spectrum, would be responsible for supplying oxygen-rich blood to the left atrium and both of the heart's ventricles. And so we can see that the heart truly is an important structure, so important that it has its own artery which supplies its own oxygen-rich blood to allow it to function properly. And so the heart also has cells, right? And just like any other muscle in our body, these cells have to function in order to allow us to contract. And the cells of the hearts are called myocardiocytes. And these myocardiocytes are responsible for allowing the heart to contract efficiently and effectively, so that it might be able to pump blood throughout the rest of the body. It's these cells, these myocardiocytes, that start to die off once the heart becomes deprived of oxygen. So we can think about it this way, that if there's a situation where the heart isn't receiving enough oxygen, so let's say either the coronary arteries just are blocked off, no blood and oxygen can get to the heart, the myocardiocytes begin to die off. And as these muscle cells start to die off, the heart loses its ability to pump like it normally would, to pump as forcefully as it normally would. And then other situations arrive, such as your muscle cells, the rest of your body isn't getting as much oxygenated blood as it probably should be. So the heart has its own special artery, which is the coronary artery, and this coronary artery is responsible for supplying the heart with oxygenated blood. This oxygenated blood really supplies the cells of the heart, or the myocardiocytes. It's when the heart becomes deprived of oxygen, so that the coronary artery is either blocked off or there just isn't enough oxygenated blood getting to the heart, that the myocardiocytes begin to die off. And when they begin to die off, we have decreased left ventricular contraction, which means we get less blood being pumped to the rest of the body. And subsequently, what tends to happen is we start to have cell death, not only occurring within the heart itself, but also within the muscle cells, the brain cells, etc. And so that leads us to the first pathology that we'll talk about, which is a heart attack, right? Well, how does a heart attack occur, or what we would call a cardiovascular accident? It's really when the heart tissue is deprived of oxygen. Remember that when the heart tissue is deprived of oxygen, those myocardiocytes begin to die off. And because those myocardiocytes begin to die off, you get less ventricular contraction, i.e., or another way to say it is that the heart isn't able to pump blood effectively. And because it can't pump blood effectively, it's not pumping out enough blood to the rest of the body, and the other body or human body cells begin to start to die off. And so with a heart attack, what we get is this interruption of the heart's electrical system, and we might even get some irregular heartbeats associated with the cell death or the myocardiocyte death. So some common causes of a heart attack, one of them is a cardiovascular disease, which is basically a disease of the heart muscle, specifically the heart muscle cells, and or the blood vessels supplying the heart, so specifically the coronary artery. What's interesting about cardiovascular disease is it's a leading cause of death among adults in the United States, and it probably has something to do with our eating patterns, which we'll talk about a little bit later. About 80 million people suffering from cardiovascular disease globally, and the problem with cardiovascular disease is that it really develops slowly, and it could be as a result of coronary artery or heart disease, which kind of is this disease that affects the inner lining of the arteries, specifically the coronary arteries that are going to be supplying the heart with blood. And typically what tends to happen is these arteries start to become more narrow. And we'll talk about a specific disease called atherosclerosis, which is responsible for the hardening and the narrowing of the coronary artery itself. And then another cause for a heart attack would be a stroke or a cerebral vascular accident, which we'll talk about as well, which is a decrease in oxygen going to and blood going to the brain as a result of some type of thrombus or embolus, which blocks off one of the arteries and or veins supplying the brain as well. So we can see that this is a what we would say it could be caused. This disease could be caused by multiple factors, and so we're going to talk about how we would identify maybe individuals who might be most susceptible to developing cardiovascular disease down the road. So the first disease that we're going to be talking about is atherosclerosis, and this is typically a disease which plagues the arteries. It doesn't have to be the coronary artery. It could be any of the arteries that are responsible for supplying any of the extremities within the body. But for the purposes of this particular lecture, we're going to be talking about atherosclerosis as it refers to plaguing the coronary arteries. And so when we think about this particular disease, we really think about is a buildup of cholesterol, specifically the LDL cholesterol. And what's going to happen is this cholesterol starts to build up and starts to build a small wall around the arteries, right? And in particular, the coronary arteries that supply the heart. And what we can see kind of in this picture below is that this cholesterol begins to build up. And so what we have here on this side is a normal artery, right? We see that there's no cholesterol buildup. It's as wide as it could be. Blood can flow through efficiently and effectively, and oxygen can also get through, and we can supply the heart. However, with years of either smoking per se, obesity, and or poor choices in our eating, what we start to see is this buildup of plaque on the artery wall. And so this might be something like 5 years, right, where our patient has just been eating bad or they're extremely obese, and we start to see this buildup of plaque on this particular artery. And what we can see is that when this plaque builds up, it narrows the space within the artery, which essentially means that it's decreasing the amount of blood, oxygenated blood, that can flow to the heart, right? So we have less oxygenated blood going to the heart because we have less room to move that blood. And we might, guesstimate that this is the artery of someone, let's say 10 to 15 years down the road, where this artery is completely blocked off by the cholesterol. And so what does this mean? Well, what this scenario presents is a scenario in which you get no oxygenated blood to the heart specifically, or to any of the tissues that might be supplied by the artery that's affected. And so what you get is a situation where you get hypoxia, which is this decrease in oxygen or no oxygen whatsoever going to the tissue that it's supplying. And so in this case, what we would say is that because there's no oxygen being supplied or blood being supplied to the heart, that our myocardiocytes are going to begin to die off. And again, when our myocardiocytes begin to die off, our heart loses the ability to contract as forcefully as it should to supply the body with blood, right? This aorta is going to be pumping oxygenated blood out to the rest of the body. Well, it loses the ability to do that as forcefully as it would because the artery is being blocked off or occluded by plaque buildup over years, right? This disease is very slow in terms of its development because it takes a long time for the plaque to build up and for the cholesterol to deposit itself on the artery. And so when we think about this disease, atherosclerosis, what we're thinking about is, when I say ineffective, is that the artery pretty much loses its ability to bring blood or to transport blood to the actual tissue that it's supplying, and as a result, that tissue, the muscle tissue, begins to die off. Now, we also have a situation where we get this acute myocardial ischemia, and so when we think of anything that's ischemic, what we're thinking of is something that's losing or has a lack of oxygen supply, so there's not enough oxygen going to the supply tissue, and specifically the coronary artery. And so what we get is chest pain or chest discomfort. So a lot of times in the emergency medical field, what we'll see is a patient who complains of chest pain. Well, the big reason for chest pain is ischemia, this lack of oxygen to the tissue or the target tissue, and as a result, specifically with the coronary artery, because we get no oxygen to the heart, to the myocardiocytes, they begin to die off. And a sign of the dying off of myocardiocytes really is chest pain. And so when you have a patient presenting with chest pain, you should automatically be thinking, okay, these myocardiocytes might be dying off. In essence, they might have a lack of blood flow and a lack of oxygen being supplied via the coronary artery. So what is a myocardial infarction? Well, simplistically stated, it's death of the heart muscle that typically occurs because the heart muscle is blocked off, meaning it's not getting enough blood flow, and that typically occurs as a result of the plaque buildup, which we talked about down here below in this picture, is that the coronary artery just becomes completely occluded, and it loses its ability to supply oxygenated blood to the heart, and as a result, the heart muscles and the cells that supply at the myocardial sites begin to die off. I think what's interesting about myocardial infarction is about 80% of all heart attack victims will experience or report sudden chest pain. Again, that goes back to this category here where we're talking about acute myocardial ischemia, which is when they don't have enough oxygen going to the heart. The heart cells begin to die off, and as a result they signal, or they send a signal to the brain, and that signal is interpreted as pain. And so 80% of patients will report some type of chest pain, and so that's a telltale sign that our patient, if they are not suffering from a heart attack, may be setting themselves up to suffer from one within 8 to 10 minutes. So as a first responder, we have to recognize the signs and the symptoms. Other signs and symptoms that may be present if a patient is experiencing a myocardial infarction would be abnormal heart rhythm. So either they have increased heart rhythm or heart rate, or they have decreased heart rhythm and heart rate. They also might suffer from nauseousness, and they might also vomit. Now, here is what's interesting. So I said 80% of most patients suffering from a heart attack or a myocardial infarction will have chest pain, but there are also that 20% who do not have chest pain, so they do not report chest pain. In this type of pathology is called a silent myocardial infarction. Well, why is it called silent? Because they don't have any chest pain, which is one of the #1 signs and symptoms or precursors to an actual heart attack. So it's a silent, we'll call it capital M, capital I, myocardial infarction. So other cardiovascular emergencies that aren't as severe as a myocardial infarction would include something such as angina pectoris. And angina pectoris literally, really, truly does mean pain in the chest, right? And so we would say pain in the chest is what angina pectoris means. And so we think about angina pectoris, it doesn't necessarily have to be associated with the fact that the patient is having a heart attack. And so it does occur when a patient isn't getting enough oxygen and blood to the heart. And this could be because of disease and or narrowed arteries. So most often the pain of angina occurs as a result of physical activity beyond the patient's physical limit. It could occur as a result of emotional stress, extreme hot and or cold weather, and sometimes, but very rarely, it could have no apparent cause whatsoever. The pain of angina can range from a mild ache to something that's severe and crushing, and typically the referral pattern for someone with angina pectoris is in the chest, but it can radiate to the patient's jaw, neck, and or left shoulder / arm and hand. So it is often mistaken as indigestion. So I just have like this chest pain and it's no big deal. However, angina pain does not always manifest itself as pain. The patient may report a feeling of like tightness, a gripping chest pain, a heaviness, a crushing sensation within the chest. So the big deal is just to recognize, first of all, what are the signs and symptoms that your patient is reporting with. And even if it sounds like it's chest pain and you're not sure of what origin it comes from, we still send them to the emergency room just to rule out a myocardial infarction, right, or a heart attack. The nice thing about angina pectoris is that it's reversible. There typically is no permanent damage to the heart muscle, and then typically you can reduce the pain by having the patient rest. I think that's one of the differentials between angina pectoris and chest pain associated with a heart attack, is that if a patient truly has angina pectoris, once we remove them from the exercise or once we lower their heart rate, the pain in the chest tends to subside with angina pectoris. However, with a heart attack patient, that isn't always the case. They sit down, they rest, their chest pain still is not relieved, it still does not reduce. So how do we treat angina pectoris? Typically, it's with medicine. Most specifically, that medicine is going to be nitroglycerin. And nitroglycerin has been reported to reduce the workload of the heart. It also vasodilates the arteries, which is a good thing. When we get arterial vasodilation, what that means is we get this widening of the artery, which allows for more blood and also more oxygen to be distributed to the heart via the coronary artery. Some other purported effects of nitroglycerin is that it can lower blood pressure, specifically with patients with a systolic blood pressure above 160. In this case, nitroglycerin would be really an effective treatment in the treatment of angina pectoris. Before taking nitroglycerin, we should always check the patient's blood pressure. We want to make sure that we don't give nitroglycerin or administer nitroglycerin to a patient who has a systolic blood pressure below 100, because in that case we would lower it, and then we would create a situation or an environment where a patient would suffer from low blood pressure, and those signs and symptoms would be things such as dizziness, fainting, or loss of consciousness, because the heart just doesn't have enough blood feeling in order to supply the rest of the body. And so we can see that angina pectoris truly is a correctable pathology if we're able to recognize the signs and symptoms. Again, the differential between a heart attack and angina chest pain is truly whether or not it goes away with rest. So the last stop on the cardiovascular emergencies is congestive heart failure. And I think that when some people hear this term congestive heart failure, they automatically think that the heart has completely stopped working. But that just isn't the case. When we think about congestive heart failure, what we're really thinking about is the fact that the heart just isn't able to pump enough blood to meet the needs of the body, right? And so this may happen when the heart muscle itself is weaker than normal, or when there's a defect in the heart that prevents it from pumping as effectively as it would. So you really get something that occurs as a result of something that we've done. Either we've eaten a lot of horrible fast food for 15 to 20 years and it's catching up with us, or it could be congenital, something that we're born with. Either way, when we think about heart failure, it's really the heart's inability to effectively pump blood or to supply oxygenated blood to the rest of the body. So because the heart does not function or pump blood or circulate blood normally, the kidneys receive less blood and filter less fluid out of circulation into the urine. So we have less fluid leaving the body. And so there's more fluid in the circulation. And this fluid tends to build up in the lungs, in our liver, around our eyes, and sometimes into our legs. And so this fluid is called congestion, which is why we get the term, or the reason that doctors call this pathology congestive heart failure, because there's no other places for the fluid to go but into our lungs, liver, eyes, and sometimes into our surrounding extremities, specifically the legs. And so we get this condition where we get increased blood pressure because there's more, the heart is having to work harder. And we also get this weight gain because we don't have the capacity to remove the excess fluid through excretion during urination. So this fluid starts to build up and our patient starts to gain weight. Now, we are concerned with patients who have congestive heart failure, and there are definitely different types of treatments and medicines that physicians will prescribe. Specifically, the number one medication that a physician will prescribe is a diuretic, or a water pill as we might know it. And what this does is it kind of helps the body get rid of the excess fluid by increasing the number of times that your patient is going to urinate throughout the day, right? A physician might also recommend a low salt diet, again, to help with reduction or retention of fluid, specifically water within the body. So there are ways to kind of counteract this congestion or buildup of extra fluid within the body. So at this point in time in the class, I'd like to ask, what do you think? Men or women have a higher history of heart disease? And so the best question is, sorry, men, you're at a higher risk for developing congestive heart failure under the age of 55. When we all hit 55, we are, I guess we could say, equal in terms of our ability to develop a history of heart disease. But men, you by far are at a greater risk of developing heart disease under the age of 55 when compared to your female counterpart. So under the age of 55, men, and then 55 and above, we're all equal And so how do we decrease our chance of getting heart disease, or how do we decrease our family members' chances of getting heart disease? And really it has to do with our lifestyles. One of the causative factors, one of the things that's heavily or highly related to the development of heart disease, specifically congestive heart failure, is smoking. Cigarette smokers are 2.5 times more likely to suffer from some type of heart disease by the time they hit age 55 when compared to individuals at the same age who do not smoke. So if you are a smoker, stop smoking now. Decreasing the amount of fat intake, so that's going to be a dietary change, right? So instead of going to In-N-Out, maybe you're going to Subway to get a salad. Instead of going to McDonald's and getting a double cheeseburger and fries, maybe you get a double cheeseburger with no cheese and no bread. And so we can see that by eliminating the amount of bad cholesterol that we're putting into our body could also decrease our chances of getting heart disease. Easier said than done for those of us who like to eat fast food often. I'm raising my hand on that one. Getting your blood pressure checked regularly is also a good technique to employ at a young age. And the reason is because you can start to identify whether or not you're developing hypertension and or high blood pressure, and you can start to get treated for that at an earlier age, so that it doesn't become a problem and so that it doesn't progress into heart disease at a later age. If you are obese or you have obese family members or obese patients, encouraging your patients to exercise and to decrease weight. It has been reported that individuals who are obese, their heart has to work at least 2 to 3 times harder in order to pump blood to the rest of the body, because there's more of the body to pump blood to. So by decreasing the amount of weight a patient the amount of weight within a patient will also decrease the amount of workload that your heart has to do in order to pump blood to the rest of the body. And then exercising is always a good way to reduce your risk of heart disease. So again, this slide kind of reiterates what I talked about on in the past slide, which is really if you want to control the risk factors, if you want to decrease your likelihood of developing some type of heart disease in the future, then really we can control some of these factors. And the risk factors that we can control, again, are cigarette smoking, getting our blood pressure checked to make sure that we don't have high blood pressure, because uncontrolled high blood pressure really leads to your heart working harder. It can also lead to cardiovascular disease or a myocardial infarction, because your heart is just working hard all the time to pump blood to the rest of the body. And then with our high cholesterol levels, one way that we can modify that is by changing kind of what we're putting into our body, putting in less saturated fats and putting in unsaturated fats that are a little bit more healthy for us as individuals. So what are the signs and symptoms of a heart attack? We've already talked about this, but the brief stabbing chest pain that a patient will have. And then in addition to the brief stabbing chest pain, the pain may range from mild discomfort to a crushing chest pain, which I've already mentioned. Your referral patterns for your patient might be in the shoulder, neck, arm, jaw, typically on the left side of the body. Your patient might also complain of uncomfortable pressure, squeezing, tightness, aching, and or constricting or a heavy feeling in the chest. The big deal is this pain does not go away with rest. Okay, so it does not go away with rest, whereas with our angina pectoris, it does go away with rest, right? And so we're going to say this is our biggest differential. So what is your role as a first responder? I think the biggest role that you have as a first responder really is going to be to recognize the signs and symptoms of a heart attack, because if you don't, then it could lead to death eventually. It could lead to your patient becoming unconscious, which eventually and subsequently could lead to death. Remember, I said 350,000 people die from a cerebral vascular accident or a cardiovascular disease within the United States. And of that 350,000 people, remember, a large majority of those individuals die being transported to the hospital. And so really prevention of death starts with recognition. That's one of the biggest things that you as a first responder, that's probably your number one role, is to recognize that our patient might be suffering from a heart attack. And that goes back to knowing the signs and symptoms. One of the interesting facts and statistics is that most people who die from a heart attack die within the first 1 to 2 hours after the first sign and symptom. So if a person complains of chest pain, you have about an hour or two to determine whether or not it truly is heart attack, a myocardial infarction, angina pectoris to get that patient treatment. If not, if we're outside of that 1 to 2 hours after the first sign and symptom, then we know that our patient has a high likelihood of dying from the pathology. And then what's interesting is that many victims delay care and wait before going to the hospital because they really don't recognize that they are having a heart attack. They just kind of, again, blow it off as if it's indigestion. By the time the signs and symptoms increase, the chest pain is getting worse, and they get to the hospital, they're within that 1 to 2 hours, and by then it might be too late. You might have irreversible cell death or myocardiocyte cell death, and by then it's just too late. And so you, as a first responder, if you could do anything, it would be to recognize the signs and symptoms, or to tell your family members what those signs and symptoms are so that they might also be able to recognize the signs and symptoms of a heart attack. So what does the chest pain pattern look like? I've kind of described it in words, but we can kind of see that our patient is going to present with pain in either in the upper shoulders, also in the sternum, and then the big one also is in the jaw or the upper portion of the neck. And this is kind of the pain pattern for someone who's suffering from a heart attack. The other big one is crushing chest pain right in the center. They will say that they feel like someone's putting their foot in their chest. These are all telltale signs that your patient is suffering from a myocardial infarction, and either a call to 911 or a drive to the emergency room is warranted. So how do we care for a victim who's suffering from a heart attack in the field? The big deal is you're going to convince, this is going to be one of the most difficult in terms of dealing with athletes in particular, is convincing your athlete to actually stop all activities, right? We have to stop all activities. Remember, we said one of the differentials between angina pectoris and a myocardial infarction is really that when you stop all activities, if it's a heart attack, the pain does not go away. So we have to stop all activities to perform our differential assessment. We're going to help the patient get into a comfortable position. Again, by doing this, if it relieves pain, again, they're probably not suffering from a heart attack. However, if it does, then more than likely it's angina pectoris. The EMTs typically come and they will deliver nitroglycerin to our patients if in fact the pain has subsided. And they believe it's angina pectoris. And then we're going to call 911 once our patient is in a comfortable position. Now, here we go again. Back to the sample. Remember your signs and symptoms, your allergies, your medications, your past pertinent histories, last oral intakes, and your events leading up to the pathology or the pain. And so we're going to take a history, right? And a history is big for a patient who's suffering from a heart attack. I want to ask them 4 major questions. When did the pain start? Because we want to know, again, how long it's been since the first sign and symptom. 1 to 2 hours, and your patient is more than likely to die, and any treatment that we would provide probably will not be as effective as it would have been if we would have gotten to them before the hour. What does that pain feel like? What brought it on? Was it exercising? Because if it was exercising, if we stop activities and the pain goes away, then it's angina pectoris. Or was it you were just sitting on a bench and your chest started hurting? And then last but not least, we want to know the referral pattern. Remember, if we go back to the picture of the referral pattern, pain pattern for heart attack, we want to know, is it in the shoulders? Is it in the upper jaw? Is it in the center of the sternum? Because those are all signs and symptoms that your patient might be having a myocardial infarction. And so if EMS arrives or if we have an oxygen tank, we want to administer oxygen, because part of the sign or the symptom of chest pain is this lack of oxygen, right? So if we deliver oxygen to our patient, we're getting oxygen to the heart. We have less myocardiocytes dying, which is a good thing because we can get more efficiency in heart pumping and in the heart's ability to pump blood out to the rest of the body. And then last but not least, if our patient does become unconscious, here's where we come in. We're going to perform cardiopulmonary resuscitation or what we would call CPR. So we talked about myocardial infarctions. We talked about cardiovascular heart disease. We've talked about congestive heart failure. We've talked about all of these cardiac emergencies, right? And one of the greatest cardiac emergencies, or what these other pathologies could lead to, is cardiac arrest. And so cardiac arrest is exactly what the name implies. When we think cardio or cardiac, we think heart, and when we think arrest, we think of the heart stopping or ceasing. And so when we think about cardiac arrest, what we're saying is that the heart has stopped beating, or it's beating too irregularly and too soft that it's not circulating blood effectively to the rest of the body. Eventually, if the heart stops beating, we get breathing soon ceasing as well. And so what we get is a situation where we get heart stopping, and then we get breathing stopping. And so what does that mean? What does that mean for our patient? Well, what it means is that our patient is getting no blood flow to the body, and they are getting no oxygen as well, because the heart isn't beating. And guess what? You're not breathing, which means you're not bringing in O2 into the environment. And this creates a deadly environment for our patients, because remember, without blood flow to both the brain and the heart, without oxygen to the brain and the heart, the cells begin to die off. And if they begin to die off, it becomes very difficult, if at all, for them to regenerate themselves. And so we have to perform some type of technique to get the heart pumping and to increase the circulating oxygen within the body, and that technique is CPR, or cardiopulmonary resuscitation. And so this is a life-threatening emergency, and if you don't know why, I've already said it: because we don't have O2 or oxygen, and we don't have blood flowing to the rest of the body. So the two signs of cardiac arrest, number one, there is no breathing. So your patient, when you look, listen, and feel for 10 seconds, there's no breathing. And then the other thing is that when you check a pulse, there isn't any pulse. There's no carotid pulse. There's no radial pulse. So in addition to no breathing, we get no signs of life whatsoever. And so the number one sign for cardiac arrest is that you cannot feel the carotid pulse, which is the pulse located in the neck next to your Adam's apple. And so what this means is that your patient isn't getting any oxygen, and they aren't getting any blood to the entire body. All of your body cells will begin to die off soon if we don't do something about that. And here's where we as first responders come in. We have to be able to recognize these signs and symptoms through our vitals check. Remember, we're going to check the airway. We're going to open it with a head tilt chin lift. We're going to assess breathing by looking, listening, and feeling. And last but not least, we're going to check for circulation or signs of life by assessing the patient's pulse, right? A pulse, when we think about it, is something we feel when the ventricles contract, right? And so as they're forcing blood out of the heart's chambers to the rest of the body, we feel that pulse, and that is a sign and symptom, or a sign of life. So in the field, we can encounter two types of patients who are unconscious. We can encounter a patient who suffered from sudden death, and we can encounter a patient who suffered from a clinical death. And when we think about something that's a sudden death, we think of someone who dies instantaneously. So death that results without any signs and symptoms of a heart attack, without any signs whatsoever, right? And we hear about this a lot in sports when we have like patients who may have had some type of heart pathology. And I kind of think of Hank Gathers, an old basketball player who dropped dead on the basketball court. He had a heart pathology, and the physicians didn't know it, and he dropped dead instantaneously on the court. In football, it happens very often in heat, when athletes are working too hard and their heart gets overworked and they just drop dead instantaneously. And so that would be considered sudden death. On the opposite end of the spectrum, we get clinical death. And this is kind of where we as first responders can come in and provide treatment. And clinical death is basically defined as that death that occurs when the heart stops beating and breathing ceases. So again, this patient is in cardiac and respiratory arrest. So we'd say cardiac and respiratory arrest. Everything stopped. Everything has shut down. Here's where we come in as first responders. So how do we care for someone in cardiac arrest? The answer to that is CPR. But also, in addition to CPR, we're also going to use something called an automated external defibrillation, which we'll talk about in another chapter. But CPR alone is not enough to help someone survive. And so what we have to remember is the chain of survival, right? And remember, there were 4 components to that chain of survival. And those 4 are listed below. So it's going to be early access to 911. Remember, that's that lay responder calling 911 and recognizing that an emergency has occurred. We need to perform early CPR, so CPR as soon as possible, and then early defibrillation. And then last but not least, we would hope and pray that advanced medical care would arrive as soon as possible to further the treatment and to get the patient to the hospital as soon as possible. But the key and one of the biggest things or components that we can do as first responder really is to start CPR as promptly as possible and initiate EMS if it hasn't been initiated already. So again, the cardiac chain of survival has 4 components. The first component, which is the most important component, really is this early recognition and early access to the EMS system, or another way stated is calling 911, right? This is going to be our lay responder. Remember, we said lay responder. We said the responder who doesn't have any skills whatsoever. Their major role is going to be in what? Recognizing that an emergency has occurred and calling 911. Then you, as a first responder, you come to the scene and you can then provide early CPR while we wait for the defibrillator to come. And then at that point in time, we would administer the automated external defibrillator. And then last but not least, we're just waiting and treating until EMS arrives to take the patient away to the hospital to get the care that they need. So these are the 4 steps in the cardiac chain of survival, and I think that when we follow these 4 steps, then it creates more efficiency in the treatment that is delivered to our patient. So cardiopulmonary resuscitation, or CPR as I'll refer to it from here on out, is a combination of chest compressions and ventilations. And so when we think about the ventilations, the purpose of the ventilations is to get air into the lungs. And we can kind of do this with mouth to mask, which we've talked about. So we could use the bag valve resuscitator, or we could use an oxygen delivery device, or what we would call a fixed variable flow oxygen, to get oxygen into the patient's lungs and then to distribute it to the rest of the body. And so the whole entire goal of ventilations really truly is to get oxygen into our patients who are unconscious and not. The other portion to CPR are the chest compressions, and I think the biggest component to the chest compressions is that it is responsible for basically causing or simulating what we would consider to be a heart contraction, right? And so a heart contraction, the whole goal of the heart contracting, specifically the lower ventricles, is to do what? Circulate, or to pump blood to the rest of the body. And so the chest compressions really simulate the heart pumping out blood to the rest of the body. And so when we have a combination of ventilations and chest compressions, you get oxygen being delivered using breathing, and then we get the chest compressions pumping out the oxygenated blood to the rest of the body. So in essence, CPR is kind of simulating the heart function within the circulatory system itself. Now, in order to have efficient, effective chest compressions, the big deal is that you have to have the correct hand positioning for maximum effectiveness. And so we want to be in the center of the sternum, and we want to apply pressure in a straight and downward manner, not at an angle, because blood will not be distributed evenly throughout the rest of the body. And then we have to make sure that we have the proper depth of compression. If your compression is too shallow, then you won't get enough blood flow. And if it's too deep, you might actually fracture the rib and or the sternum and hurt your patient even more. And so we're going to learn the process of chest compression during lab in class. So here are the current standards and ratio for CPR for an adult, child, and an infant. For an adult, we're always going to be using 2 hands in the center of the chest, in between their nipples. And these 2 hands are going to be placed on top of each other, and we're going to use both hands to compress. Again, we will do this in lab. For a child, depending on their size, you can use 1 hand and or 2-hand technique in the center of the chest nipples. And then for an infant, because remember their bones and their musculoskeletal system is a lot more fragile, you don't need more than 2 to 3 fingers or 2 thumbs within the nipple line to compress the chest. And so when we think about compression depth and the efficiency and the effectiveness of our chest compressions, for an adult, we really want the chest to be compressed at least 2 inches, if not more. For a child, no more than 2 inches, and then for an infant, no more than an inch and a half. And so when we think about the depth of chest compressions, again, it changes from an adult, child, and infant, and it makes sense. Adults are larger, so they require a greater depth of chest compression, whereas infants are smaller, so they don't require as great of depth to circulate blood throughout the rest of the body. I think it's here in the chest compression to ventilation ratios where we really pay attention to the ratios, because they're going to change a little bit. And so with a single rescuer, this is the red box that I'm drawing now, all the way across the board from adult, child to infant, the ratio is 30 chest compressions to 2 ventilations. However, if we have a scenario where we have 2 trained first responders, the ratio changes for the infant and the child. So when we have 2 rescuers, we're going to do chest compressions, a ratio of 15 chest compressions to 2 ventilations. And so you might say, well, why did they change? Well, the biggest reason is because we want to get as many breaths and chest compressions into an infant and a child, because remember, their circulatory system works a little bit quicker and they breathe faster than we do. And so because of that, we want to have less chest compressions, because then we'll get more chest compressions and ventilations into our infant and our child within the 2 minutes. However, with an adult, we're not concerned because our breathing ratio or our respiratory rate is a lot lower than the child and the infant. So with 2 rescuers, the ratio for child and infant changes again to 15-2. The goal of CPR would be to get 30 chest compressions in about 23 seconds. And so you want about 100 chest compressions per minute. And so we'll practice that in lab as well. So I always get this question of, when do we stop CPR? The honest answer is you really don't, okay? The only time that there are 7 reasons that you can stop CPR. The first one is if a person of equal or higher training, okay, so I say training there, but equal or higher training takes over. If advanced medical personnel arrives, if for some reason you are doing CPR and the heart starts beating and your patient starts breathing, if the scene becomes unsafe for you as a first responder, remember to remove yourself. If a defibrillator, so if the defibrillator is on the scene, then we can stop CPR and set that up and perform the defibrillation and then go back to our CPR. If you notice after you've started CPR that there's a do not resuscitate, then you can go ahead and stop. And then last but not least, if you become exhausted, which could be the case if we're looking at response times of EMS, sometimes they're 7 to 10 minutes. And so you've been performing CPR for 7 to 10 minutes and you're just too exhausted to perform CPR, then you can stop. Otherwise, you just keep going until EMS arrives. So remember in chapter 6 and 7 when I was talking about respiratory emergencies, specifically when we went and talked about children, what I said was that typically the cardiac emergency that is going to occur usually occurs as a result of a respiratory emergency that was not cared for or that was not recognized. So another way to state that is that your child has a breathing emergency, and for whatever reason that goes unrecognized, they stop breathing and eventually the heart stops beating. So typically in our child or our children community, we could really decrease the number of cardiac emergencies if we were to recognize the respiratory emergency before it gets to the cardiac level. And so cardiac emergencies are definitely preventable in children. The big deal is obviously trying to prevent injuries, specifically respiratory injuries, or to our children during either swimming or running, etc. And then the other thing is that we give proper care. And the biggest deal is just this idea that we need to recognize the respiratory pathology first, and this could prevent a lot of the cardiac emergencies that we're seeing in our child population. So some of the signs and symptoms, again, the child might be agitated, they might be more tired than usual, change in skin color, specifically they're probably going to be cyanotic. Remember that blue colored appearance, which represents a lack of oxygen getting into the body. They might have difficulty breathing, and they probably will have increased heart rate and breathing rates, right? So we have this increase in respiration, and when you check their pulse, it's also going to be elevated well above the 80 to 100 beats or beats per minute that you normally might see in a patient who you're assessing their pulse. And so recognition is the key to avoid cardiac emergencies in the child population. So I leave you with this schematic since I am such a visual person. Here's how the assessment works in an unconscious patient. If we encounter a patient who is not breathing, they're gasping for air, they just don't have good breathing, and they're unresponsive, our next step in this process is really going to be to activate 911, to call 911, or to have someone do it for us. Once we do that, the next thing we're going to do is we're going to check a pulse. We're going to check a pulse for no longer than 10 seconds. In an adult, we are going to check the pulse at the carotid if they're unconscious, and in a child and an infant, we're going to check the brachial pulse. If there is a pulse, then we are going to perform rescue breathing. So we'd say this box here, so rescue breathing. If there is no pulse and they are not breathing, then we begin CPR. If there's one rescuer, it's 30 chest compressions to 2. If there's 2 rescuers, then for a child and an infant, then of course we will perform 15 chest compressions to 2 breath. When the AED arrives, the next thing that we're going to do is have it check the heart rhythm, and then from there we kind of can branch off, and we can say if they need shock, we deliver a shock, and then we start our CPR all over again. If they don't need a shock, so the AED determines that they have a normal heart rhythm, we go for CPR for 2 more minutes, and then we reassess the heart rhythm with the AED. And so this is just a schematic of all that I've said throughout this entire lecture. I hope that this helps you in determining whether or not a person needs CPR and or rescue breathing. So this concludes our online lecture. You will have homework for the next class period, so that I know that you have a great understanding of the CPR ratios and the process that involves determining whether or not a person needs CPR and or rescue breathing. And so I want you to turn in your own drawing and depiction of the CPR ratios, and then I also want you to draw your own schematic or flow chart for determining whether or not a patient needs CPR and or rescue breathing. This will be due at the beginning of the next class period. Thank you for your time.